information about ways and recommendations for keeping your children healthy and hopefully free, or at least with reduced numbers of infections. Okay, so what is our immune system? So our immune system keeps most people healthy most of the time. We all get sick every once in a while, right? We all might need to take antibiotics to get well. But in general, most people are healthy for the majority of their life. And the way our immune system does that is with different types of cells, proteins, and in fact, body organs that work together or sometimes separately to protect us from infections. And it's happening all the time, whether we know it or not. We're constantly exposed to bacteria or viruses, and our immune system is working to protect us from infections. Our immune system does this by recognizing danger signals. Danger signals are bacteria, viruses, fungus, or other pathogens that we're exposed to on a daily basis. This picture is actually a food particle, and it's covered with bacteria. And I put this in my talk to remind people that we're constantly exposed to these types of pathogens, and our immune system is constantly recognizing them, fighting them off, and protecting us from infection. So one problem with immunology as a specialty in medical school is that it's the least popular for medical students in their training years. And if this were a medical school of maybe 100 or 200 people, this is about all of the students who would show up for the immunology class. And at the end of the session, probably the front row would be the only people left. And unfortunately, and I make a joke about that, but unfortunately, that impacts a lot of the physicians who take care of your children. So unless you are interested in immunology, you may not have ever paid attention to the class where you were supposed to learn about these cells. And after you're out seeing patients in the real world as a physician, you might never think about the immune system again or the different problems that can occur, for example, in patients with Jacobson syndrome. In some ways, at the end of this session, you might know a little bit more than your pediatrician or your physician about the problems that you might see in Jacobson syndrome. So let's get started. Okay. So to make this easy, these are little cartoons about the different parts of our immune system. So I mentioned this already, and our immune system needs to recognize some sort of danger signal or enemy. It can come in different forms. I mentioned bacteria or viruses, which are the most common causes or the most common types of danger signals. But also fungus or fungi can be a big problem for infections of the skin. Physical barriers are also an important component of our immune system. The biggest immune system organ in our body is actually our skin. It acts as a physical barrier and shields our organs our bloodstream, and other parts of our body from pathogens like bacteria and viruses. Our mouth, our nose, our middle ear are covered by mucous membranes which protect us from invasion with bacteria and viruses by secreting proteins and cells that immediately neutralize or kill those danger signals before they infect us. These body fluids are very important in the initial response to infections, and they sometimes can even flush bad guys or danger signals away before infections set in. The most important cell in our immune system is called a T cell. This is the cell that sometimes is abnormal in patients with Jacobson syndrome. And it has two very important roles in the immune response to pathogens. First, it communicates with other cells by secreting chemicals and proteins that tell them what to do. And we call it the communication link of the immune system. Certain types of T cells also directly kill the bacteria or viruses before they can infect our bodies. And you can imagine if our T cells are damaged or broken, or if we don't have T cells at all, our immune systems are crippled and unable to respond to infections. Those T cells, I mentioned, secrete proteins and chemicals that talk to other cells. And the cell they talk to most are called B cells. These B cells are important because they secrete neutralizing and killing antibodies which defend us from bacteria and viruses. And they function over a long period of time to produce those antibodies. Some B cells make the initial response to an infection by secreting a type of antibody, which I'll mention in the next slide. And other B cells live for long periods of time, secrete antibodies that protect us for years and years so that we don't get the same infection more than 2 times. I'll mention in a slide coming up that B cells might also be abnormal in patients with Jacobson syndrome. And we know this because of the research that Dr. Dalm did at Rotterdam in the Netherlands. Antibodies are very important in protecting us from infections. These are proteins that are secreted by B cells and that circulate in our bloodstream all the time, 24/7. Each antibody that is made by a B cell is specific for a unique bacteria or virus. These immediately kill bacteria and viruses. They can neutralize the toxins that bacteria or viruses secrete that cause damage to our cells. And they also stick to the bacteria after they're killed and allow for our immune system to clear those bacteria or dead cells away and allow for our organs to heal after an infection. So you can imagine if we don't make protective antibodies, our immune system is crippled. It can't protect us from infection, and if an infection occurs, that infection will probably last longer and have more consequences for our organs. And so all these cells, the T cells, our B cells, our antibodies, and then other components I didn't mention, act like a team. They have a very organized, killing bacteria and viruses, and then cleaning up the mess when everything is done. And unfortunately, in Jacobson syndrome, that team doesn't really talk to each other and is probably abnormal in almost all patients. When our immune system doesn't work well, we have a name for that, and it's called immune deficiency. Our knowledge about the immune system in Jacobson has evolved tremendously over the last 10 to 15 years. Before I saw my first patient with Jacobson syndrome, physicians recognized that patients with 11q deletions got sick more frequently. They had more infections of the ears and of the sinuses. But what they believed was that those infections were the result of abnormal skull formation, right? The facial bones probably weren't formed in the correct way, and bacteria and viruses were able to live in the middle ear or in the sinus cavities and evade the immune system. But soon, some physicians realized that patients with Jacobson syndrome might also have low antibody levels. Some patients with Jacobson syndrome were treated with immunoglobulin replacement or antibody replacement. But it wasn't recognized that many patients with Jacobson syndrome were susceptible to infections and probably had abnormal immune systems. Only in about 2010 was it realized that infants were born with Jacobson syndrome, and when they were born, their immune system was already damaged. This occurred when, in the United States, we began screening for immune deficiencies in many children in different states. That test was designed to identify patients who did not have any T cells, which I mentioned earlier. And occasionally, a patient was born who didn't have the disease that the test was looking for, but instead had Jacobson syndrome. And so they quickly realized that some patients with Jacobson syndrome were born with very low T cell numbers. And since that time, we've realized that many patients with Jacobson syndrome, and probably all patients with 11q deletions, have some form of an immune deficiency and are susceptible to infections. So how do we test for immune deficiency in Jacobson syndrome? Okay. So unfortunately, the only way that we can test for immune deficiencies is with blood samples. Testing typically requires a blood sample on different occasions, so on multiple days. And we usually do this in a stepwise approach, which I'll mention in a future slide. Blood testing is required to measure those T cells and B cells and make sure that they're present in the normal numbers. And we also need to test to see whether those T cells and B cells function normally. And we do that by using a special vaccine and measure children's response to immunization. We can measure antibody levels before receiving the vaccine and then afterwards, and then compare that to what we would normally expect in other healthy children. Okay, so what symptoms in 11q deletions might suggest immune deficiencies? I'm sure that when I go through this list, some of you will recognize these symptoms in your own children. I mentioned before, many children with Jacobson syndrome have chronic upper respiratory tract infections. This includes ear infections that require antibiotics, sinus infections, and also lung infections. Some patients might have chronic diarrhea. It's very common for patients with T-cell deficiencies, which is what we see in Jacobson syndrome, to have skin infections with Candida or other types of fungus. This picture is of a skin infection with a fungus that in the US we call ringworm or tinea. It's a very common infection in children, but usually it goes away very quickly. What we might see in patients with Jacobson syndrome is difficult to treat, and it can impact or affect especially the feet for many, many years in patients with Jacobson syndrome. We've recognized that patients, especially in Dr. Dahlm's cohort of children and adults, have recurrent or severe warts of the hands and of the feet. In normal children, these warts typically only last several months, and treatment with chemicals or physical destruction often leads to cure. But in patients with Jacobson syndrome, these warts can last for years, and they can last long into adulthood. Okay. So there are three main types of immune deficiencies that we see in patients with Jacobson syndrome. As immunologists, we have names for them, and I think it's important that you be familiar with these terms so you can ask your physicians if they've done the testing to make these diagnoses. The first type of immune deficiency is called hypogammaglobulinemia, and it's a very general term where we describe patients with low antibody levels. If a patient has hypogammaglobulinemia, it means that their B cells are not able to function to make those antibodies. And it might be a deficiency in any one of the three different types of antibodies that I list here: IgG, IgA, or IgM, or sometimes a combination of more than one of those antibodies. Patients with low antibody levels typically have recurrent infections of the ears, sinus, and lungs, but they don't have warts or other skin infections that I mentioned in the last slide. Most of the patients with mild or moderate hypogammaglobulinemia respond to treatment with antibiotics or sometimes with replacement of those antibodies in the form of immunoglobulin. The treatment with antibiotics can sometimes be done with long-term dosing over months to prevent infections, or sometimes with use of antibiotics only when infections occur. The second type of immunodeficiency that we see in patients with Jacobson syndrome is called lymphopenia. Typically, it's T-cell lymphopenia, and it occurs when patients have low T-cell counts or the T-cells that they do have don't function normally. These patients are the patients who have recurrent skin infections with viruses such as warts or fungus. And while the infections can usually be treated with medications, the T-cell deficiency cannot be corrected, and the deficiency is typically lifelong. And there's a third type of immune deficiency where both there is a B-cell problem and a T-cell problem, and they have low levels of antibodies and usually some sort of T-cell deficiency. These patients have a combination of infections, so they have recurrent ear, sinus, and lung infections, and sometimes skin infections or other problems of the immune system. These are usually treated with antibody replacement in the form of immunoglobulin infusions, which I know some patients are receiving in the room today, and also with antibiotics to both prevent and treat those infections. So we have hypogammaglobulinemia. I know some patients in the room who have that. Lymphopenia. In the US, I know a patient who has very low T-cell counts, and I'm sure some patients here today also have low T-cell counts. And then common variable immune deficiency. We often will see it written in the medical record as CVID or CVD, depending on the country that you live in. Some countries use different acronyms or names. Okay. The last slide is relatively old news now. We've known about those different problems for about 10 to 15 years. But this is a little bit more recent. And so initially we thought that the deficiencies seen in Jacobson syndrome were from T-cell problems. Either T-cells didn't communicate with B-cells, or T-cells weren't present at all and unable to do the job. And it led to a B-cell problem where they didn't make antibodies. But we now know that there's probably some component that impacts the B-cells either directly or the signal from the T-cell prevents B-cells from developing normally themselves. So there is a form of a B-cell called a memory B-cell. And I mentioned before that those are B-cells that produce antibodies to protect us long-term. They're constantly making antibodies so that we don't become sick with an infection we have seen before. And what Dr. Dalm showed in Rotterdam with his team is that there is a subset of B cells called memory B cells, which are deficient in almost all patients with Jacobson syndrome. And I don't have my pointer, but the graph on the left side of the screen shows a group of normal patients. Let's see. So these patients here are normal patients. And in general, they make normal or high levels of this memory. These are Jacobson syndrome. And you can see, oh, they can't hear, sorry. So these are normal patients. They make normal levels of memory B cells, and they make normal antibody levels. These are Jacobson syndrome patients. They make very low or no memory B cells. And because of that, they either make low levels of antibody or they don't produce those long-term protective antibodies that will prevent infection with bacteria or viruses that second time. And it explains why patients with Jacobson syndrome sometimes need to be treated with antibiotics for many, many weeks in order to clear infections. And after infections are treated, they come back. And so that's new information that I think everyone needs to be familiar with, because we can test for those memory B cells now. And 10 years ago, we did not have that ability. So the way that we've recognized children with immune deficiencies in Jacobson syndrome has changed dramatically over the past 10 to 15 years. And I put this slide just so that you can understand how all of these how this new understanding of immune deficiency and Jacobson syndrome can benefit all the newly diagnosed patients. So in the past, patients were born and they were recognized to have Jacobson syndrome because of a heart defect or abnormal facial structure or low platelets. They were then cared for by pediatricians, by cardiologists, and maybe a few patients were referred to an immunologist for an evaluation because they had recurrent infections. And maybe laboratory testing was done, and maybe those patients were identified as having an immune deficiency. But now that newborn screening is standard in all states in the US, and also standard in many countries in the EU, that may be an opportunity to identify a patient with an immune deficiency very early on. And even if the test doesn't identify a patient at birth, the information that we now have and the way that immunologists understand Jacobson syndrome might lead to much earlier diagnosis of patients. And so conferences like this today can help all the children with Jacobson syndrome get the evaluation that they need to identify any problem or deficiency in their immune system. So in 2017, Virgil and I got together with Paul, and we talked about what we could do to make the evaluation of these patients with Jacobson syndrome a little bit easier, right? There was already a protocol for treatment of bleeding prior to surgeries and other interventions, and we felt that developing an immunology protocol might be beneficial as well. And so we put together some guidelines, and this protocol is available on the web. It's a PDF file. You can download and print it, and you can bring it to your pediatrician, and you can make sure that he or she has done all of the required testing or ask for a referral to an immunologist so this testing can be done. I think all newborns, once the diagnosis of Jacobson syndrome is made, should have T cells measured either by the newborn screening test or by measurement of T cells via a separate blood sample. This can be done soon after birth, and it can help us understand whether there might be a very severe deficiency in the newborn patients. Around the age of 4 to 6 months, we can measure immunoglobulins or antibody levels. And at 12 months, we can test to see if the immune system of patients is functioning to respond to vaccinations. And so we measure the antibody levels for the vaccine preventable diseases such as tetanus and diphtheria. And around 2 years of age, we can measure to see if they respond to vaccination with Pneumovax. That's a vaccine that's used in all kids to protect against a common bacteria that can cause ear and sinus infections. By giving Pneumovax and measuring children's response to that vaccine, we can do two things. First, we can protect them from infection with that bacteria, and that will reduce the frequency that they get ear infections and sinus infections. And we can also challenge or measure their response and make sure that their immune system is functioning normally. Our protocol also recommends a consultation with an immunologist. And there's a list of immunologists on a few websites that I will provide at the end of this talk today. And that's in almost all countries in the EU. In general, routine vaccinations are safe and effective for patients with Jacobson syndrome, unless there is a known severe T-cell deficiency. So patients who are born, who are identified as having a severe T-cell deficiency at birth, can receive all of the normal childhood vaccinations, with the exception of the vaccine for rotavirus, if it's available in your country, or the MMR vaccine, measles, mumps, rubella, or the varicella vaccine. So to repeat, most childhood immunizations are okay. I would wait to get rotavirus, MMR, or varicella. Almost all children with Jacobson syndrome can get those three vaccines eventually, but in the first year or two of life, it's best to wait until your immune system has been fully tested by an immunologist and we understand the extent of the immune deficiency that they may or may not have. It came to Paul's attention years ago that a patient with Jacobson syndrome had severe illness with RSV, which is a common virus that affects children and causes, in most kids, a mild to moderate respiratory tract infection. But he had heard about a patient with Jacobson syndrome who had a very severe course and unfortunately passed away from that infection. And so in talking with Virgil and I, we felt that we needed to strongly consider the use of a medication called Synagis, which can protect infants from that disease and hopefully prevent that very tragic consequence that that child suffered from. This medication called Synagis is already used for patients with congenital heart defects in the first year or so of life because they're at high risk for severe RSV infections. And many children with Jacobson syndrome have heart disease and are already taking Synagis in that first year or so. But we know that not every child with Jacobson syndrome needs congenital heart surgery. And so using this in all patients with Jacobson syndrome might be a big benefit and prevent RSV. And I also mentioned in a previous slide, using Pneumovax in all patients to both prevent infection with that bacteria and also challenge their immune system so that we can identify the presence of an immune deficiency. I think when most people go to their pediatrician with an infection, they leave with some sort of antibiotic prescription. It's very common. But sometimes pediatricians will wait a while and not give you that prescription for antibiotics. And I think that's probably fine in most children. But in patients with Jacobson syndrome, I would advocate the opposite. We know they have an immune deficiency. We know they get recurrent infections. And so as physicians, it's our job to treat those early so we can prevent the complications. I also think it's important to use antibiotics for longer periods of time in patients with Jacobson syndrome. And so for families who have a child with Jacobson syndrome and then other children without, you might see a difference in the way that they respond to antibiotics. Patients with immune deficiencies commonly need higher doses of antibiotics or longer periods of treatment in order to get well. Where normal children can get a 7 or 10-day course of antibiotics, clear their infection, and be back to normal quickly. Sometimes immune deficiencies take a while to present on blood testing. What might be normal early in life can change, and as years go by, we may notice that the B cells stop producing antibodies, or children start getting infections with bacteria more frequently. And so if you notice a change in your child's overall health, typically infections that start to become more frequent or more severe, it's important to revisit an immunologist or your pediatrician and ask for retesting to see if those blood tests have changed. And then I talked earlier yesterday with a few different families about the use of prophylactic antibiotics. Prophylactic antibiotics are important for use in patients with immune deficiencies because it can prevent infections before they begin. Prophylactic antibiotics are used in all patients with low T cells because they're susceptible to different types of infections than normal children. And even if your T cells are normal in number, prophylactic antibiotics can reduce the frequency of ear and sinus infections that we commonly see in patients with Jacobson syndrome. There are different regimens that can be used. Some of the antibiotics can be given daily, for example, Bactrim or amoxicillin. And there's another form called azithromycin, which can be used 3 days a week, once a day. So depending on your child's other health concerns, one of those antibiotics can be very helpful in reducing the frequency of infections. And I promised that this year we would finally maybe update that protocol with some new information. I'll save everyone a talk about COVID. We did that last time. But there's a few things I do want to put in that protocol. After the US meeting in June, I plan to do a formal update of the protocol and have it published on the website. But here's what I'm proposing in terms of new information. Number one, I'd like to add some information about the memory B cells. That test is now pretty readily available in many different laboratories around the world. And if it's not available in a commercial laboratory in your country, I know that a research immunologist can fairly easily do it at one of the centers in the EU. So where before we didn't put it in the protocol because it was hard to find that test, in 2024, it's pretty standard to do that test on all children with Jacobson syndrome. COVID vaccination. Rather than give specifics about the use of COVID vaccines in Jacobson syndrome, we know that Jacobson syndrome is an immune deficiency disorder, and you should follow the COVID vaccination recommendations in your country based upon the licensed products and the prevalence of the disease. And using antiviral medications for illness with COVID is also important based upon the age and the risk factors that they might have. And we should consider Jacobson syndrome patients as being high risk for COVID infection based upon their immune deficiencies. And they should get treated with antivirals as early as possible. Okay, so in summary, our immune system is very complex. You don't need to remember everything that we talked about today. If you remember the words T cells, B cells, and antibodies, I think that's a win. And if you remember that the T cells and B cells talk to each other and make those antibodies, that's even a bigger win. All patients with Jacobson syndrome probably have some form of immune deficiency. We may not be able to measure that in the blood testing we do. We may not see a low T cell count. We may not see low antibody levels. But we know that those T cells might not work perfectly, and those antibodies might not fully protect us from infections. And so the paper that Virgil published was very important because it made a very bold statement that Jacobson syndrome is a syndromic immune deficiency. And what that does is it allows your physicians to treat your children with either immunoglobulin replacement or antibiotics to prevent infections without questioning from the healthcare system. We're still unsure about how that immune deficiency might present itself in different patients. We don't know how we can predict which patients might have severe infections or profound immune deficiency compared to patients who might have more normal appearing immune systems. That's research that still needs to be done. But I think it's very clear that all patients with Jacobson syndrome need to have that immune evaluation done and be under the care of an immunologist to both prevent and treat infections. And with that, I'll leave this slide as my final slide. And this is some resources that people can use to find an immunologist in your country or in your city. Some of these immunologists partner with the Jeffrey Modell Foundation. which is a global foundation dedicated to the identification and treatment of patients with immune deficiencies. I helped a family yesterday by getting on the JMF website and identifying an immunologist in Belgium. I emailed her, and within an hour, she emailed me back, and she will contact the family for an appointment as soon as they can. The Immune Deficiency Foundation is an organization in the United States, which is a patient and family advocacy organization. They also have a list of physicians. And their counterpart in the EU is IPOPI, or the International Patient Organization for Primary Immunodeficiency. I encourage everyone to take a look at one or more of these websites and see if they have a program or information that might benefit your family or your children, especially if your children have a known immunodeficiency or are receiving immunoglobulin replacement. They have lots of resources on any of these websites. IPOPI has a conference that moves around the EU for patients and families. And in the US, the Immune Deficiency Foundation has the same. And with that, I'm going to hold on questions because we're going to take a quick break. 10 minutes, Camille? 10, 15 minutes. Think about questions you might have for me when we return. If you want to write some questions down on a piece of paper, that would be fine. I can give that to the translators, and then we can translate all the questions, and I will do my best to answer them. Yep, so Camille has some papers and pens. Sebastian's going to take a note taker. And we can write the questions there when we're done. Perfect, yeah. Good.
are in German. And then they said, well, in 6 months you have 6 tests, and
In German.
4 of them are oral examinations. So you have to talk to the professor in German. Okay, I have to learn German. No, we are being taught German in school, but that's 2 hours a week for 5 years still doesn't teach you
One of
to.
the times I was here with Virgil, we were driving around, and I'm like, well, you can speak German, right? And he's like, I don't speak French, I don't speak German, I don't speak anything except for Dutch and English.
Well, it stops with me with like 75% German. I can understand it very well. So yesterday I didn't need my earphones, but I think my vocabulary is a bit
And you
small.
can understand it if you know the context. If you
Yes.
know, if you know what to expect, you know.
Well, I think we're gonna get started.
Okay, cool.
So I suppose everyone is back in again. So let's start with the questions, see if the translation works for Ken. So we had quite a few questions on the board. Please don't hesitate to ask any further questions once we're done with these. So I'm going to start out with the first one. Maybe first a general one. Can you comment on the importance of sleep and diet on the immune system?
Okay. Is the microphone on?
Yes.
Okay. So what's important to remember is that the immune deficiencies that we see in Jacobson syndrome are genetic in basis and hardwired into your children's body. So any of the deficiencies aren't going to be changed by sleep or diet. Sleep and diet are important, but they're not going to fix the immune deficiency themselves. If you're missing T cells, there is no diet change that will help your body make more T cells. Does that answer the question? Yeah.
Okay, on to the next one. The 3 main types of immunodeficiencies in Jacobson talk about infections. Are Jacobson patients more at risk to infections rather than viruses?
So, yes. So I group all infections together: virus infections, bacterial infections, or fungus infections. Depending on which form of immune deficiency you have, you might be more susceptible to one of those types of infections. So if you have T cell deficiencies, you're more likely to have infections with viruses and with warts. If your immune deficiency is more of the antibody deficiency or B cell deficiency, you're more likely to have infections with bacteria, like ear infections or sinus infections. So depending on which form of the immune deficiency your child has, it can sort of predict which of the individual types of infections you're likely to see. It's not a perfect science, though, because there is crossover between the different forms of infections.
Okay. If anyone wants to follow up on a question, just raise your hand if yours is dealt with and you want to follow up because it's not answering the question, then please just raise your hand. So another one, are regularly blocked ears a function of immunodeficiency or a consequence of the narrow sinus and ear canals?
That's a great question. So the ear infections that I talk about in Jacobson syndrome are behind the eardrum in the middle ear cavity. The infection occurs in a very small space inside of the middle ear. And what you're describing with the tiny ear canals is on the outside of the ear. And so those are two different problems that we see. One is a structural problem where the ear canal is very narrow and makes it difficult for physicians to see the eardrum. And that can sometimes also cause some irritation or external infection of the skin of the ear canal. But the ear infections we typically see are on the other side of that eardrum and are usually from bacteria that are living in that very wet environment inside of the ear. Nigel.
It was more to do with the regular production of too much wax and a blocking, rather than a specific infection.
So the production, I don't think there's any wax production issue in Jacobson syndrome that I can think of. I don't know if that's something that's seen in patients.
Die Ohrinfektionen sind meines Erachtens auch dadurch, bitte? Die Ohrinfektionen kommen häufig auch dadurch, dass die eustachische Tube, der Verbindungsgang zwischen Nase und Ohr, flacher gebaut ist durch die Deformierung des Kopfes, steht das leichter und dass die Kinder auch nicht so gut ausschneuzen können, also eher hochziehen und dadurch die Bakterien im Prinzip in dem Bereich des Innenraums der Nase und des Ohres produzieren.
Yes, so that abnormal, it's called the eustachian tube, and it is a connection between the middle ear cavity and the nasal passages. And if your facial structure is abnormal, sometimes that tube that drains the middle ear cavity into the nasal passages gets blocked. And that is a structural or anatomic reason for more frequent ear infections. There's a normal production of fluid in the middle ear cavity. And if that fluid doesn't drain naturally into the nasal passages, bacteria can set up a very comfortable home in that fluid. They begin to multiply, and it can cause a bacterial middle ear infection. So that's the reason why 10 to 20 years ago, we knew patients with Jacobson syndrome had frequent ear infections, and we blamed it on that eustachian tube dysfunction. But now we know that the other reason why patients get ear infections is because of the immune deficiency. And so it's probably a combination of factors, of anatomic differences and poor antibody production.
Brauchen meine Kinder einen Bluttest, wenn sie eine interstitielle Deletion haben? Sie haben keine Symptome mehr, aber früher häufig Ohreninfektionen.
So this is a question I get every time. What to do about someone who has never had a test before, but is older and is doing okay? Do I need to know if they have an immune deficiency? And my answer every time is it can be very helpful to find out if your child is at risk for frequent infections, because it might open an opportunity to treat with antibiotics earlier rather than wait until symptoms become severe. And so there's only a benefit to knowing if there's low antibodies or low T cells. There's probably no harm in doing that test to find out if there's any form of immune deficiency in your child. But I understand that some children have gone for many years without severe infections and have never had their immune system tested. But it can be very helpful to know.
Perhaps a question tapping into the same topic. Does it make sense at a higher age to do the Pneumovax 23?
That's a great question. So that's one reason why I would advocate for everyone to be tested in terms of their immune system. I look at the use of Pneumovax 23 as an opportunity to improve the ability to fight off infections, even in patients whose evaluation appears to be normal. Vaccines, and specifically Pneumovax 23, are tools that we have to improve the overall health of patients with Jacobson syndrome and reduce their infections. In addition to Pneumovax 23, there are other vaccines that can protect against that bacteria. One of those vaccines is called Prevnar, Prevnar, and that's approved to protect children and adults from infection with a common bacteria that causes infections. So yes, there is a benefit to Pneumovax in all patients with Jacobson syndrome.
Okay, we had a question on the YouTube channel. Somebody was asking, I was wondering how 11q duplication is affected. Our little boy was told he had low immunoglobulins as an infant and then had low response to first vaccines, but the most recent vaccine they said was in range. Could he still be affected? He had a lot of infections as a baby, but has been most healthy for a year.
So while we're mostly talking today about chromosome 11 deletions and the immune deficiency that is seen in Jacobson syndrome, as an immunologist, I'm aware that many chromosomal abnormalities can lead to differing forms of immune deficiency. I am not surprised that other patients, for example, patients with 11q duplications, have problems with their immune system, especially in the infant period. And it's not surprising to me that over the time frame that she mentions in the question, it appears that things did improve. We see that in other disorders too. And if the response to vaccines has improved now that the child is older, that's a positive sign that the immune system has gotten better over the years. Our immune system is just like other parts of our body with a normal expected development. Normal children are expected to walk, at some age between 9 months and 15 or 18 months. But some children have delays and don't walk until they're 2. And eventually most of those children will run and play sports, but their walking was a little bit delayed. Our immune system is no different. We know that the production of immunoglobulins and the response to vaccination follows an expected developmental course. In patients with Jacobson syndrome or other chromosomal abnormalities may have a delay in that expected progression. But eventually, most of those patients develop normal or near normal immune systems. The problem with Jacobson syndrome is that many of the immune system problems we see don't improve over time because either the T cells or the B cells are missing or low or not functioning properly because of the chromosome abnormality. And we don't completely understand why Jacobson syndrome has that immune deficiency yet. So most of the cases of low immunity in the infant period get better with time. And it's hard to predict when or if it will improve. Question.
Ich habe da ein, ja, ja. Ich habe da einen gewissen Konflikt. Auf der einen Seite sagen wir ja, das Immunsystem muss sich programmieren durch Erkrankungen, durch die Konfrontation mit Keimen und Ähnliches, damit es Immunglobuline bildet. Und gleichzeitig wird empfohlen, weil die B-Zellen so schlecht sind, dass eine kontinuierliche Antibiotikagabe empfohlen wird. Gibt es da eine Leitlinie, was man machen soll und welche Auswirkung hat die Gabe von Antibiotika prophylaktisch?
Yes. So there have always been concerns about using antibiotics and the side effects from long-term use and whether that has a negative impact on your immune system's development or ability to learn to fight off pathogens like bacteria or viruses. But in the case of using antibiotics for Jacobson syndrome or for immune deficiencies, we feel that the benefit outweighs the risk of any side effects. Your immune system is exposed to bacteria and viruses all the time, like I mentioned in my talk. And using antibiotics only prevents the infection or the harmful impact of those bacteria or viruses. It doesn't have a negative impact on the way that your immune system develops.
Noch eine Frage, die ein bisschen weiterführt. Sie hatten erwähnt, dass das Synagis als monoklonaler Antikörper auch prophylaktisch eingesetzt werden kann gegen RSV-Viren, was ja was ja eine
That's okay.
ausgesprochen gute Wirkung hat. Aber es ist in Deutschland nur zugelassen bis zu einem Alter von 2 Jahren. Gibt es da andere Erfahrungen oder welche Erfahrungen gibt es mit dem Synagis?
Can you repeat the question for the translator?
So,
That's okay.
ach so. Ja, für das Synagis ist ja ein monoklonaler Antikörper und wird empfohlen als Prophylaxe bei RSV-Virusinfektionen. Es hat in Deutschland eine Zulassung bis maximal 2 Jahre, soll monatlich gegeben werden, prophylaktisch. Welche Erfahrungen gibt es darüber?
So I think the question is about the use of Synagis as a monoclonal antibody to protect infants from infection with RSV. And we don't have specific data or research about using it for Jacobson syndrome, but we do have extensive experience about using Synagis for patients with other immune deficiencies and with congenital heart disease. And so we make the recommendation for using Synagis to protect infants because we know that the consequences of RSV infection can be severe. And the benefit of using Synagis outweighs any potential risk. All of our infants in my practice that have severe immune deficiencies, not Jacobson syndrome, but other severe immune deficiencies, receive Synagis on a monthly basis until we are able to get them to a bone marrow transplant or other therapy to cure their disease. And so we use that experience to make decisions about patients with Jacobson syndrome.
Perhaps a follow-up on the Synagis now that we're on this topic.
Sure.
How long does the Synagis vaccine work? I was told by my pediatrician it lasts just a few weeks and needs to be renewed more often than other vaccines.
So Synagis is an infusion of monoclonal antibodies. What Synagis does is it protects infants from infection with RSV by providing them with already active antibodies that will attack the virus before it can cause an infection. Antibodies have a natural half-life or lifespan of approximately 1 month. And so when we give immunoglobulins or monoclonal antibodies like Synagis, we have to constantly redose or infuse another dose of that medication after the antibodies start to dissipate or go away. And so the infusions of Synagis are a recurring infusion for the first 1 or 2 years of life. It does not stimulate the immune system at all. It's what we call a passive transfer of immunity, which is different from the active immunity that you get from vaccination or exposure to the actual bacteria or virus.
We had one question twice, actually. I'll
It
put
means
it
it's
in English,
important.
but it will be translated in German. To what extent does pretty much everything you presented apply to interstitial patients as well. So where they miss like a middle part of the chromosome and not the end.
Yeah, so because we're unsure of the cause of the immune deficiency in Jacobson syndrome or the correlation between the location of the deletion and the extent of the immune deficiency, I can't make a prediction about which patients will have mild problems or more severe problems. Some patients that I've talked to have never had infections, have normal appearing immune systems, and others were diagnosed with T-cell lymphopenia and low antibody levels soon after birth. And I don't know which patients will have that disorder or not. To be continued. Paul has a question.
Just so that we catch it on the video.
So just to follow up on Ken's response, there can be interstitial deletions anywhere in chromosome 11, or for that matter, any chromosome? But what I would suggest is just for any interstitial deletion in the region that causes Jacobson syndrome, I would follow exactly the same approach as for those with the more classic terminal deletion.
So the immune deficiency that we see, it is very obvious that it is a huge spectrum of problems. And like I said just a minute ago, it's almost impossible right now to predict because we can't see the immune system without a lot of testing. Some of the other issues that we see with Jacobson syndrome are very clear with just our eyes. The developmental delays, the problems with communication, the motor skill delays are very easy to see the differences between patients and how they're patients who are very strongly affected by Jacobson syndrome deletions and others that have much more mild problems. But the immune system the immune deficiencies require a lot of testing before we can make a judgment.
How often should a full immune system evaluation be repeated if no signs of aggravation? In this specific case, the last one was 5 years ago.
So in general, I think that it would be reasonable to repeat an evaluation of antibody levels and potentially T and B cell numbers if the clinical signs have changed over time. So if there was a young child who had the evaluation done and everything was normal, and they went through their school age years and into young adulthood without a lot of infections, there's probably no reason to repeat the testing. The initial testing effectively proved that there were T cells in place and that those T cells and B cells were making antibody. But if that child started to go into young adulthood and began to have ear infections or developed warts that never went away, or other skin infections that were hard to treat, I would want to know if that had changed, because it might change our decisions about treatment. But if otherwise everything is fine and there's no new issues, I don't think there's a reason to repeat the blood testing over and over again.
Okay. More specific one, is Bactrim better for the gut than amoxicillin?
Great question. So we mentioned prophylactic antibiotics in our talk. And prophylactic antibiotics can be very beneficial to reduce the frequency of infections, especially in the winter months of the year when patients tend to get more frequent ear and sinus infections. And in general, in my practice, I have 3 different antibiotics that I consider to use to prevent infections. The first one is amoxicillin, which I affectionately nicknamed the pink stuff. And that's simple because it's the one we all know, right? Everyone has had a child with an ear infection, and they went home with a 7-day prescription of the pink stuff twice a day. And the benefit of that is that it's familiar to us, but there, of course, are some side effects of daily antibiotics. The other option that I have for prophylactic antibiotics is Bactrim, which is usually once or twice a day. For prophylaxis, I usually prescribe it 1 time a day. And it's in general pretty well tolerated. But it also has some GI or gastrointestinal side effects when we use it long term. And then there's another medication called azithromycin. The brand name is Zithromax. And we use that with a dosing schedule of once a day, 3 days each week, Monday, Wednesday, and Friday. And that's a benefit because it's less medication and in some cases, less side effects. But they're all pretty effective when used appropriately. There could be other regimens. I've heard of patients using an older version of erythromycin, of azithromycin called erythromycin for other reasons. Some patients might use antibiotic in the class called cephalosporins or Keflex on a daily basis. But they also have side effects. Gesa.
If you come across a child that every time it gets antibiotics has either a fungus infection right afterwards or has severe outbreak of warts right after the antibiotic treatment, what would you recommend? Rather leave the antibiotics or do it and deal with the fungus afterwards?
It's not uncommon to see a fungal infection, specifically yeast infections, either vaginal yeast infection or oral thrush or yeast infections that occur with the use of antibiotics. And in some cases, physicians will prescribe an antifungal medication along with the antibiotic in order to prevent that from happening. In my experience, if a patient was using prophylactic antibiotics and had issues with fungal infections, I would probably discontinue that specific antibiotic and try a different version. Or maybe try probiotics to improve gut health and maybe reduce the chance of yeast infections. But that is not unique to Jacobson syndrome patients at all. We see that in everybody.
Is it advisable or helpful to boost multivitamins, D, C, all that sort of stuff, in autumn or throughout the year, or not at all?
So in general, I think in the Western diet that we all have, and the fact that most of our food is enriched with vitamins, true deficiencies in vitamins and minerals are pretty rare, and there's no need for excessive supplementation of certain vitamins or minerals. And I don't think there's a specific benefit for our immune system with most of the vitamins, like vitamin C that you mentioned. We get plenty of those vitamins. The exception might be vitamin D, because vitamin D has been shown to be low in many people because we're typically avoiding sun exposure. And in Northern Europe, we don't get a lot of sun for a good portion of the year. And so vitamin D deficiency is pretty prevalent. And there have been studies to show that vitamin D supplementation can improve some aspects of our immune system function. But remember that in Jacobson syndrome, the deficiency is not from diet or nutrition reasons. It's because of the chromosomal abnormality. And vitamin D or other vitamins won't fix that.
Eine Frage auf Deutsch. Unsere Tochter hat Hautprobleme auf der Kopfhaut. Starker Schorf. Kennen Sie so etwas? Was kann man tun?
So I haven't heard specifically about scabs or sores on patient's scalp. But when I hear that story, it makes me think about fungal infections of the skin on the scalp that lead to itching and probably picking at that skin, creating open sores that don't heal. So I don't think that the scabs are a direct result of the immune deficiency, but more likely secondary to the symptoms of those skin infections with fungi or fungus that cause itching and picking at the scalp.
Yeah, we're running a bit out of time. So
Always.
we yes, we already skipped some question because I think it was already answered in other ones.
But what we can do is, if we need to move on, I'm going to be here. So if people have questions, I'm more than happy to answer questions.
So yeah, I think it's a good choice. I think we're going to make Gesa keine Pause und gleich, ja, gleich Isabel. Ja. So, Vivian. We have to thank very, 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 very much again for you being here. And
Yeah, yeah, I know. But thank you for coming, and I think you're leaving at lunch. Okay. Perfect. No break, Isabelle. Yeah. Perfect. You're here. Yeah. Sorry.
You know what time they leave for the wildlife?
ich muss den Ton.
Actually, I don't know.
Wir haben gesagt, Sie haben ein Brummen auf der Leitung, wenn ich den Ton von Laptop hochdrehe. Deswegen würde ich ihn dann hochdrehen, wenn die Videos kommen. Ne? Ja. Das mal Bescheid.
Können wir zwei Handmikros nutzen?
Ja.
Thank you.
Ich glaube, es werden keine Fragen dann danach kommen.
Hallo.
Isabel,
Was
Isabel, langsam. Bleib bei mir. Bleib bei mir. Stell du die da hin. Warte mal schnell noch. Was, wenn der Gero sagt, dass du nicht da bist?